Over to you.
Thank you. So can I load my PPTs?
Yes, sir, please. Yeah, the slides are visible.
Okay, so my slide visible.
Yes.
Thank you. So thanks to the organizers. It has been a pleasure to be a collaborator with this activity. Now, it's fourth year of this particular conference, and I'm very happy that Dr. Vaishali was very thoughtful to put my presentation after some of these esteemed people, Professor Gangadhar, Dr. Joshi, Dr. Leena Phadke, Karuna Madam, and Prashant, who brought in already the various aspects of the health and wellness to the fore. So it makes my task that much easier. What am I going to do next few minutes is that I am going to talk about these four headings. So first is what is the evolution of the concepts related to health and wellness over last several years, and how do we measure health, and what is the implication for clinical practice and clinical research, and then about this particular method of measurement called as the clinical global impression, which is predominantly there for measurement of illness, and a new development in the form of adopting this theme of clinical global impression for the measurement of health as well. So all of you will appreciate that we all grew with this WHO definition of health. Given to this year, we have the 75th jubilee of this definition, the Amrit Mahotsav of this definition, 1948 definition, that health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So although this definition has been there for a really long time, and as I said that as medical students and as later as medical practitioners, we all have grown with this definition, but this definition itself had its own positives and negatives. The most important positive to my mind is that this definition basically sets up a higher bar. So it sort of tells the doctors, the medical people, the healthcare people that don't just be satisfied with illness control. So strive for health attainment so that you make efforts so that your clients attain health and not just illness control. But while this positive is true on the conceptual side, there have been a criticism, that it had certain limitations, this particular definition or this approach, that it did not really give a very practical way of assessing health. So it did not really tell people. In concept, it seems fine that we shouldn't just have a freedom from illness, but we should have a very positive state of being. But it did not really give a practical way how to assess that. So in the end, we couldn't really move much beyond illness control in our clinical practice as well as even in our research. And moreover, despite World Health Organization 75 years ago emphasizing the different dimensions and facets of health, we know that the mind-body dichotomy still persisted despite that. So the dichotomy between the disorders of the mind and the disorders of body, they get treated in a separate way. And somewhere down the line, therefore, as a consequence of all these, we got lost in an array of lab tests. On one hand, physical lab tests, on the other hand, certain psychometry, and people continued to work in silos. So although the definition opened up some very good idea for us to move forward, it could not really deliver practically so much on the ground. After this initial effort by the World Health Organization, and in fact, it is a part of their preamble. If you read the WHO website, it's part of the preamble of their constitution, about this whole ideas about health and health as a resource. So the which developments came thereafter is a first one, you can say, important one milestone is a Ottawa Charter of 1986, which emphasized that good health is a very important resource and therefore effort should be to attain good health. Then came in, after quite a gap, you can say in 2009, a conference called as the Dutch Roundtable Conference, and in which again a lot of experts from all around the world, they gathered for this roundtable conference, and they suggested that instead of talking about the state of health, let us move towards a more dynamic one based on the resilience or capacity to cope. And if you remember, speakers before me, whether it is Dr. Shashank Joshi or Dr. Leena Phadke, they already spoke about resilience, significance of resilience. That health should incorporate the resilience or capacity to cope and maintain, restore one's integrity, equilibrium, etc., and the sense of well-being. And therefore, the preferred view on health was that the health is the ability to adapt and to self-manage. So not just actually a state of positive being, but somewhere a individual's effort and the ability to adapt to one's own external internal milieu and to self-manage oneself. Of course, then other groups also worked on these ideas over a period of time. And we find that the American Heart Association, they came out with a concept called as ideal cardiovascular health, and wherein they put some metrics in place consisting of several factors, which includes some biochemical factors as well as the biophysical ones. And very interestingly, this idea finds good support across the specialties, in the sense that it doesn't only predict heart health, but is also useful to predict the brain health. So people who enjoy ideal cardiovascular health, so to speak, and this was, I would say, one of the first efforts to operationalize this idea that what health could be. Then in 2017, another researcher, Card, he came out with the idea that health is the experience of physical and psychological well-being, and that good health and poor health, they are not merely two categories, so it's not that the entire humanity is in the two buckets of all the people who have the good health and the people, those who have the illness, but it works basically as a dimension, so as a continuum. So people, those who are distributed on it. And then in 2017, another researcher and a thinker, he spoke about that the health must have some kind of a natural design to it, so it's not just that you can say a very superficial feature of organisms and human beings, but it's something which is very deeply imbibed natural design. So these kind of a different set of, as you can see here, concepts as they came along over a period of time, basically reflect, people's zeal and the desire to operationalize the ideas which the WHO came out with, so that people can use it in a practical way. Of course, then there is a body, as previous speakers, they mentioned, on the side of biological research, the laboratory research, as well as very elegant epidemiological and clinical research, which essentially showed that the mind and body, they are very intimately connected. And the neuroimmune and endocrine systems, the neurological substrate, as well as the hormonal and the immune system, they all are interlinked, and they basically sort of provide a biological basis to this mind-body connection. Another important milestone while all this was happening, people on the clinical side were doing, there was also a very interesting theoretic work, more on the mathematical engineering side was also happening. And these people, Glass and Mackey, they came out with a very elegant idea wherein they sort of systematically looked at the rhythms of life. And then they found that the healthy rhythms of life, they fluctuate within a range, and what technically is called as that the biological system has a non-linear sort of a dynamics. What it implies is that there is a nice flow of these rhythms, and there is a healthy fluctuation within that. Professor Karuna as well as Dr. Shashank Joshi, in their presentations before me, they emphasized actually a great deal, about the sleep and other rhythms. And also Dr. Leena Phadke in her presentation mentioned this, making use of this idea. Harvard cardiologist Goldberger, he looked at actually what is the healthy cardiac dynamics, and this also fits it, that it has a nice healthy fluctuation. So put all these ideas together, there was a, you can say, motivation for us to venture into this domain of measuring health. And two particular occasions sort of motivated us more. Our mentor, senior mentor, Professor Bhavsar, we were celebrating his 80th birthday a few years ago. And then there was this Vaibhav meeting. Vaibhav is the acronym for the Vaishvik Bharatiya Vaigyanik. This was a meeting which was organized by the Prime Minister's office of consisting of Indian scientists as well as the other global scientists. And the idea was to look at that how to make further strides into the integrative medicine. And the question which came up during that meeting was that, do we adequately capture health in our clinical research and intervention studies? Or do we really measure only a very small part of the illness? Or do we really sort of in a good, nice way able to capture about the patient's health in all our clinical research as well as intervention studies, means clinical trials, whether the clinical trials of new medicines or clinical trials of non-pharmac interventions? And the answer was that no, our whole assessment itself is very limited. So when we assess an individual, a patient, a human being, we only tend to look at, we have a bit sort of a biased assessment which only looks at the disease and disease complication part. And we don't really look at actually the entire part of this individual's health. And you can call it as a low ceiling effect, which means that the ceiling of our measurement itself is very low, so we are unable to comprehensively assess an individual. And because we are unable to do that, so we are not really able to understand, whether our efforts are really generating a positive health for our clients. So with these motivations, we sort of tried to synthesize a concept of health. And I have put as bullet points some of the, you can say, key features of this synthesis. So the first point naturally is that health is whole. So mind and body, they are inseparable. There's no point to be sort of entertain this dichotomy, mind-body dichotomy any longer. So mind and body are inseparable, completely clear by the research evidence. And also that health is dimensional, so humanity cannot be just put into these two buckets, that people, those who have illness and all those who don't have illness are automatically healthy, but it's a dimensional thing. And of course, then it has a natural design, the rhythms, the order, the rhythms being in order, that is the natural design for the health. And that health is dynamically created among interaction in the external and internal milieu. Just before me, Shashank Joshi sir, he spoke about the internal milieu and its interaction with the gut microbiota. So not just the milieu outside us, but also the milieu inside us, that how very critical to creation of health. Now, health is a aspect of subjective experience. We should be able to feel it. And last but not the least, very importantly, adapt and self-manage. To be resilient, is also important part of health. So health is all this. There's the dimensional approach. On one hand, you have the disease state and the complications, but on the left-hand side, you also see that there could be varying degrees of a healthy ordered system and even a resilient system, which is more resilient, to which can have a better ability to recover from difficulties or adapt to change without really being affected. So it effectively tells us that people should have, with good health, the ability to regulate whatever they can and to endure, whatever they cannot. Now, coming out of this whole conceptual understanding, that where World Health Organization started and where a lot of other researchers and wise people, how they tried to make this concept, take this forward so that it could put to more practicality. Let us look at some of the, you can say, important frameworks that how we measure. One such, you can say, very important scale, an idea of measurement which is employed in the clinical trials of new medicines, new interventions, is called as a CGI, the Clinical Global Impression. It's typically, of course, used for clinical global impression of illness. And it was authored by a guy in 1976. So this sort of a measurement scheme has been there for a long time. And what does it exactly measure? So it not only measures the illness severity, but it also measures or assesses what is the clinical impact of this particular illness on the patient's functionality, the real life functionality. So both the illness severity as well as its impact on the patient's functionality. It's a very well known, validated scale, relatively straightforward. Of course, it needs training to be able to clinically assess that. So what effectively is done is that a clinician has all the data available from the history, from the clinical examination, as well as all the lab tests together before her or him. And then the clinician is able to assign a rating to the patient's current situation as to how severe and impactful the current state of the illness is. It is clinician rated. And as I said, clinician considers all the data available for making the rating. Initially, it was used more commonly in research related to the central nervous system. So in psychiatry, neurology, neuropsychiatry, pain medicine, but subsequently it has been adopted for use in many other illnesses, as well as for evaluation even in clinical practice. And people also later thought that instead of just having one single measure, putting the entire illness in one place, it is also useful to have subscales in some instances. So there is a CGI for measuring the illness severity, and for clinical trials, there is also a version called a CGI improvement, so that you can see that before the treatment, how is the patient's CGI overall global rating, and with the intervention, how much the improvement has taken place in the patient. And as I said, very important outcome measure, which is used at part of the clinical trials. Here is you can say this rating scheme. So normal, not at all ill, borderline ill, mildly ill, moderately ill, markedly ill, severely ill, and among the most severely ill patients. And of course, all these have clear-cut definitions, which are called as anchors, so that people can get a training, and then they are able to have a very good inter-rater reliability. So even if different raters are rating the same patient, they can come to the same conclusion about the patient's clinical state. We thought that we should adopt, it's a wonderful scheme, we should adopt it for the assessment of health as well. And the anchors, as I said, are the description or definitions for each rating useful for accuracy of rating. And we have also put, unlike the CGI illness, we have also put the category for positive health, which is over and above the normal rating. So compared to, as I showed you here, that one is a normal rating, normal, not at all ill. So we have put a category which is above the normal rating, which is about adaptability and resilience, which is the main consideration for rating positive health. It is assessed on 8 points, which can be seen as maybe you can call them as pillars of health, and which all have emerged through research evidence. And as I said, I'm really thankful to all the speakers before me, because they have already highlighted these pillars of health. This whole research evidence is summarized in this particular reference, which I have put here, is a book chapter which we have written called as Mind and Cardiovascular Disease, Mechanism of Interrelationship. So this entire research evidence from laboratory as well as epidemiological and clinical studies, which we have used to describe these pillars of health, is summarized in this particular publication. They have been clustered under vital rhythms and the mind or positive psychology pillars. So these 8 we have clustered 4 + 4 in 2, and they are the ones here. The 4 vital rhythms as part of the clinical global impression of health. First one is sleep. I need not overemphasize the significance of sleep. There was a whole full-fledged presentation on this afternoon. And then the digestive cycle and nutrition. Dr. Shashank Joshi already spoke about that. And energy cycle, exercise, fitness, overall the vitality also has a lot of significance in this all modern literature, already touched upon by the speakers before me. And Dr. Prashant, again, a full-fledged presentation on sexual and reproductive health, and that how it contributes to the overall health. Then the mind pillars. First one is a feeling of comfort, as a positive feeling, positive state of emotionality. Then psychological engagement with daily activities and work. very important finding emerged through a lot of elegant research, particularly regards to occupational health, that people's health is dependent to a great extent, on their engagement with life on a daily basis. Shashank Joshi sir already mentioned this. Optimism and hope, very important pillars of health. He already touched upon that. And the self-control, which includes freedom from addictions and treatment adherence. So we put, you can say, these 8 factors together as the, you can say, indicators of health. And then we made this scheme that how to rate them. So as I said, that over and above the normal, we have the positive and regulable and positive and resilient categories, so that the entire dimension patient could be rated on this entire dimension. So people having a positive state of positive health, people having a so-called normalcy, people having a mild problems, and people, of course, having identifiable clinical and more severe problems. And how this is rated, of course, this need a bit of a training to do that. But the most important instructions are considering your total clinical experience with this particular population. How healthy is the patient at this time? So instead of asking that how ill the patient is at this time, you ask yourself this question, that how healthy is the patient at this time, and make use of all the information as well. In order to make clinical judgment, please use information available from all the sources: patient self-report, information from relatives, case notes, clinical examination, and lab investigation. So in other words, you are summarizing all the information available at your disposal to make to a clinical judgment as to how healthy the patient is at this time. In case there is a health problem, consider its frequency of occurrence, severity, distress, functional impact to assign the most appropriate rating. Make use of the anchors provided, and specify if the health which the patient is currently enjoying is supported by any medicine or treatment, and ask about resilience to assign rating of higher state of health. And of course, then come to a considerate judgment about it. As I said, needs a little bit of a training about this. This is just an example from one of the points, how to assess the sleep, that how to assign, when to assign the positive and resilient rating, how to assign, when to assign positive and controllable rating, when to call it normal, when to call it borderline mild problem, when to call it a moderate problem, when to call it a severe problem. This is all completely aligned, as I said, with this internationally standard tool called as CGI. So there's a proper structured way of doing this, and it yields reasonably good information to complement the illness information. Let me just summarize it before I close, that this idea, CGI health, is a way of measuring health in a practical way. And as I said, our journey started with that WHO came out with this concept, but the practical way was lacking. And that's why CGI health somewhere tries to fulfill this agenda. It gives us a tool, a simple clinical tool in the hands of clinicians as well as researchers, in which we could measure the patient in a very comprehensive way. CGI health also has a version for self-rating or self-assessment by patients, what is called as a PGI, patient's global assessment of his or her own health. Now we have a good experience of using CGI-H and PGI-H in diabetes population, rheumatology population. I'm sure that some of our colleagues, they are going to make presentations about that and going to present some empirical data to you. And this experience has been very encouraging, to say the least, because the combination of CGI illness and CGI health, it provides a very whole picture of patient. By the way, the meaning in Old English, the health stands actually for whole. So a combination of illness and health, if we assess the patient from both the perspectives, it gives us a real kind of a good holistic picture, and which I think Leena madam said in her presentation, very famous, someone made a sort of expression that good assessment is half the intervention done. So if we are able to comprehend patient, our clients in a better way, we are able to offer them a better intervention, and thereby fulfilling the dream which WHO floated 75 years ago, that we are not looking at just end of illness, but we are looking at the beginning and betterment of health. And this is the last one, why we need to do this, why we need to shift our attention just from the illness to let us not be illness obsessed. Let us try to look at the illness and health in a more balanced way. Because this famous person, and I use this slide in many of my presentations, because he said that doing the same thing over and over again and expecting different results. So if we are really seeking health, we also need to look at our own methods by which we are making the measurements, the assessments in a different way. Because continuing with our ways which we used up till now is not going to allow us to have any different or better results. So it is therefore necessary that we all need to think about that. We have all gone through this training, wherein it is imbibed in our mind that we need to something better for our people, not just freedom from illness, but aspiring to help them get their health. So thank you so much. And it was a wonderful meeting so far. And my best wishes for the speakers who are going to follow. I think this time this is going to be very substantive and very interesting, because different speakers are adding kind of a great value, as I said, to all these ideas. And I hope that this whole experience will help us move forward on this agenda in a more very practical way this time, rather than merely discussing about these ideas in conceptual form. It will help us to translate them in our day-to-day clinical practice, as well as the research that we do, a new thinking. Thank you so much. Thank you.
Thank you, Dr. Sanjay Phadke. After that wonderful talk, all of us need to move ahead with this novel concept of wellness assessment in patients.
Excuse me, sir.
And yeah.
So can you stop your screen, sir?
Yeah, sure.
Yes. Yeah. Yeah. So we, after having discussed in details this novel concept of wellness assessment in patients,